Left, we have Mr. Russ Guerin. Mr. Guerin is responsible for implementing the community relations, marketing, public relations, managed care, strategic planning, and business development strategies for Carolina's healthcare system. Mr. Guerin came to CHS in March 1987 as Vice President of Financial Services and has held multiple positions in the organization. He had previously served as a manager with the accounting and consulting firm of Deloitte & Touche. Mr. Guerin holds a Bachelor of Science degree in accounting from the University of Illinois and a master's degree of health systems management from Rush University. He has 28 years experience in the healthcare industry and is a fellow in the American College of Healthcare Executives. Please welcome Russ Guerin. Dr. Sheeta Galani, Business Development Manager, is responsible for the generation of new collaborations and alliances for the David A. Murdoch Research Institute. She obtained an undergraduate degree in applied biology from the Georgia Institute of Technology in Atlanta and continued her education at the University of Alabama at Birmingham, receiving a PhD in microbiology with a focus on developmental and clinical immunology. After completing a postdoctoral fellowship in ES Sales at Mount Sinai School of Medicine, Sheeta relocated to the Charlotte region. Currently, she works in business development at the DHMRI located at the North Carolina Research Campus in Kannapolis, North Carolina. In addition, she is co-founder of the North Carolina BioConnect, a biotech and life sciences professional group in the Charlotte region. Sheeta and I are also members of the Valentine Y 5 AM Club. Good to see you, and please welcome Sheeta. Dr. Don Bradley, Senior Vice President for Healthcare and Chief Medical Officer for Blue Cross and Blue Shield of North Carolina, holds faculty appointments at Duke University of Medicine and the University of North Carolina School of Medicine as a member of the North Carolina Institute of Medicine. He was appointed by Governor Easley to the North Carolina State Health Coordinating Council, where he chairs the SHCC Committee on Quality, Access, and Value. He serves as a member of the Executive Committee of the North Carolina Healthcare Quality Alliance and is a chapter member. A family physician by training and demeanor, he completed his medical degree at the Medical College of Virginia, family medicine residency in Harrisonburg, Pennsylvania, and a Kellogg Fellowship, biostatistics work, and a master's in clinical leadership at Duke. He practiced in rural Virginia before joining the Duke Family Medicine residency in 1981. Dr. Bradley's accomplishments over the last 20-plus years at Blue Cross Blue Shield of North Carolina include leading implementation of open access online medical policy, development of extensive primary care provider performance feedback, the institution of the annual State of Preventive Health Forum, implementation of comprehensive benefits and programs for the medical assessment and treatment of obesity, healthy lifestyle choices, and creation of one of the nation's first bariatric surgery centers of excellence, programs, and performance-based provider reimbursement. He regularly teaches at the Duke Clinical Leadership Program, the Duke Physician Assistance and Physical Therapy Program, and he balances it politically in North Carolina at the UNC School of Public Health. Welcome, Dr. Bradley. And last but definitely not least, Mark Billings was born in Elkin, North Carolina, and now resides in Charlotte. Mark retired from the Navy in 2004 as a lieutenant commander. His last assignment was as the operating officer for the Naval Hospital at Camp Lejeune. Mark joined Novant Health in 2004 as Vice President of Support and Professional Services for Foresight Medical Center. In 2005, he became the President of Presbyterian Hospital Matthews. In 2006, his role was expanded to include the Growth and Development Officer for Presbyterian Healthcare. In 2008, Mark was selected as President of Presbyterian Healthcare, and in 2010, Mark was named President and CEO of Presbyterian Healthcare. Mark has a graduate degree in Business Administration from New Hampshire College and a master's degree in Healthcare Administration from the University of North Carolina, Chapel Hill. Mark commits himself to the economic and medical health of the community by playing an active role in several local and state organizations. Recent appointments include the Charlotte Chamber Board of Directors, the 2010 North Carolina Hospital Association Policy Development Committee, the Medic Board, and the chair of the 2010 Greater Charlotte March for Babies. Mark is an avid sportsman and enjoys following the Tar Heels, the Bobcats, the Braves, and the Panthers. Please welcome Mark Billings. As I shared earlier, we have a very, very distinguished group that will be addressing your issues today, but I want to kick it off right quick. And again, I said I want to stand down here so I can see your eyes as you see. But for me, economic development perspective, healthcare is something that we've determined to be very important in this region. From your perspective, whether it's from the service provider side or from the research side or from the insurance side, give me your observation relative to this industry and its impact on the Charlotte region. Mark, we'll start with you.
Thank you. Thank you all for coming today. Thank you for inviting all of us. Can you hear me okay? First, to respond on the economic development of the healthcare system as a whole. Fortunately, in our community, we have, I believe, the luxury of having 11 world-class healthcare organizations in our community. We have different logos, different banners, but we typically stand for the same thing, and that's quality healthcare for those that seek it within our community. I think that in itself is a very sound talking point for business leaders when they're seeking other industries to relocate to the Charlotte area. You take a look at some of the businesses that have come to this area, one of the key things they typically ask is, how is the quality of health care? Both health systems in the greater Charlotte market are nationally ranked on their overall quality of care. So that being said, I think it's a key component of us successfully bringing industry into the Charlotte area. From a direct standpoint, two of the largest employers in our community are our two health systems. Both the Presbyterian Healthcare and the Carolinas Health System are two of the largest employers, typically rank in the top 10 in our area. And most of these jobs are quality jobs, long tenured jobs, nursing, but also support staff. So I think it's a key economic engine to any community, and particularly in Charlotte, that you have the healthcare systems that we have here to continue to grow from an economic development.
Okay, thank you, Mark. From the other service provider, in Russ.
Oh, thank you. Well, I think just to add on to what Mark said, you know, the healthcare system is sometimes overlooked as an economic engine. We're often looked at as a community resource for sure, but if you look at the economic impact of your healthcare providers in the community, you know, it can be a real eye-opener. We do an economic impact study. A third party comes in and does it for us. We have operations in both the Carolinas. And if you look at the jobs that are either directly attributable to one of our organizations or a job that's there as a result of our organization being there, in the two Carolinas, it's almost 100,000 jobs. So as Mark pointed out, not only are we often the largest employer in the community, but we also have a lot of jobs that are associated with us being there. And we try and keep healthcare local because the jobs need to be there. And we oversee a lot of community hospitals where if that community hospital wasn't there, it would be a significant detriment to that community. So, you know, I'm glad we're here talking about healthcare and talking about it in terms of it being an economic driver.
Well, Russ, we talk about a lot of jobs. Tell me a little bit about the quality of those jobs. I know the physician, but beyond the physician, what about the quality of the job?
Well, again, most of the jobs that are in healthcare are jobs that, number one, are well-paid jobs. They're jobs that require significant education, which supports our educational system. The wonderful thing about healthcare is, you know, the salaries that we pay stay local. That money is usually spent local. It's a great economic engine for whether you're in property, whether you're real estate, whether you're in retail. those dollars in general are going to be spent locally. So they're very good jobs. They have very good benefits associated with them. So, you know, and on the physician side, you know, again, we attract some of the world's best physicians to this community. And I think, as Mark pointed out, that the quality of healthcare here, you know, we just recruited Dr. Eric Ragavan from Cleveland Clinic. He ran their cancer program. He's going to run the new Levine Cancer Institute program. I mean, that is an economic driver, I can assure you.
Sheena, your perspective is a little bit different, but give me your insight on the impact. I think when the North Carolina Research Campus was first announced, and the unprecedented collaboration of universities in this state and the public and private sector, and the strong leadership of David Doe Murdoch, and really the amount of private sector money that went into it, I consider watching it come up out of the ground. I've said before publicly, probably one of the most exciting economic development projects I've been involved in. From your perspective, can you tell us a little bit about the economic impact that's projected for that particular facility on this region in the state of North Carolina?
Absolutely. I think the North Carolina Research Campus, it represents what is coming in terms of life sciences and biotechnology. If you haven't kept up with our project, they broke ground in 2006, and by 2008 we had 3 buildings up and running. We had 8 universities represented, several private companies. I believe the most important and relevant accomplishment of the campus has actually occurred in the last year with the opening of the Rowan Cabarrus Community College facility. Because what this does is it brings in people to the campus who are not PhD level scientists, but are associate's degree recipients or people who have gone back for second careers. And so it represents really an economic growth at a different level from what originally was projected. When they first broke ground, there was a study done by Market Street that the city of Kannapolis conducted, and the impact was 37,000 jobs over a 20-year period. We also, if you look at when we opened our doors, it was October 20th of 2008. So from an economic standpoint of where we were in our country, we weren't exactly at the highest point. That said, we've seen a very steady increase of jobs over time, not only on the campus, but ancillary positions and companies going up all around the campus to support us. So we're on the right track. We think that we will not only employ up to 5,000 scientists, but everything that comes with that, the support technicians, the restaurants, the shopping, everything needed to create this biotech community that Mr. Murdoch has envisioned.
Without a doubt, the economic downturn impacted the growth that you were experiencing out there. Are you beginning to see activity pick up?
Absolutely. We have recently seen Monsanto. They actually, next month, will be expanding their presence on campus and probably hiring some scientists. USDA has brought scientists to the campus recently. We have several other opportunities that are in the works, and hopefully from the private sector side, we will see more investment in that campus within the next year.
Great. Well, Don, from a statewide perspective, and speaking for this room, you probably touch a lot of us in this room in some way.
We hope so.
Some of us like you, some of us might not. But from your perspective, give us the insurance provider's perspective of the industry and the impact, not only in this region, but I guess your perspective is a little broader than just Charlotte region.
So I'm going to give you a story, good news, bad news. The good news is, first of all, we do have exceptional healthcare providers in the state, and Charlotte in particular. We've got the research institutions, we've got Triangle area, we've got Duke, UNC, NC State, NCCU, we've got Wake Forest. So we've got really a plethora of great institutions in the state, and that's great. So in terms of attracting business, then can you get good health care in the state? If you have insurance, the answer is yes. The second good news piece is that health care accounts for about 16% of our economy, and it's growing. That's also the bad news story. At the current rate, by 2019, it'll account for 20% of our economy. And the issue there is that when you're spending more money, if you're a healthcare provider, that's great. But if you're trying to develop other business, we're taking capital out of the market and spending it on healthcare. So what is good on one hand is also not so good on the other hand. We predict at the current rate that we'll see about 6% growth in healthcare expenses. The gross national product is growing at what, 2 to 3%, and disposable income is growing at 2%. So we are outstripping people's ability, in particular, to buy health insurance, but also for businesses to afford the care that's there. So I see this as a mixed bag. We're certainly heavily, totally invested in North Carolina. We live here. We cover about 3.7 million people. Charlotte is, by a good measure, one of our largest markets, and we are well ensconced in the community. But we are going to have to deal with the cost side of this as we go forward.
Since Charlotte is one of your largest markets, we can talk about the headquarters in Raleigh. We've been known to move a few things out of Raleigh.
You can get that glass.
I couldn't let that pass. I'm sorry. Ross, I think Don's perspective, though, is a very interesting kind of the good, bad piece of that. And I know you're positioning your facility for growth, Mark's positioning for growth. But give me your perspective on that dichotomy of the good and bad side of the impact on the overall economy.
Well, the one thing that I'm going to say that Don said something about if you have insurance, you get good health care. I'll tell you, in this community, that's not the case. You get good health care whether you have insurance or not. And one of the things that we have in this community are institutions that treat everybody regardless of their ability to pay. You do not go through wallet biopsies. You do not have people who are stopped at the door for any reason. So I just want to make that perfectly clear. We treat everybody with great health care. And there's a lot of people in the community that benefit from that. Our community benefit in healthcare last year is $500 million that we provide in free services of one kind or another. So it's a pretty significant contribution to the community. But I think in terms of just following up to what Don said, I would agree. There are challenges ahead, without a doubt, in terms of this economic piece of the healthcare cycle. But if you look around us, we all know that we contribute to that problem ourselves. We're seeing obesity quickly become the nation's crisis that smoking has been. And a lot of employers are represented in this room, and I think there's a lot of things that you can do with your employees to focus on wellness programs that will have an impact. But clearly, this 6% increase, which is a pretty good increase considering what we've had in the past few years. The way we're going to address this is going to have to be through some kind of lifestyle management changes, and lifestyle changes that we can do whatever we can to impress upon our employees. Because otherwise, we are looking at a population coming up that will be the first population in, I think, recorded history or ever that will not live as long as the age cohort before them. And I hope we all start taking it seriously. Thank you.
Okay. Mark, your perspective?
I think there are a number of things that we need to recognize. First off, regardless of whether you're in the 1/3 of the general population that feels that healthcare reform ought to be expanded, or the third that thinks it's just right, or the third that thinks it needs to be watered up, thrown in the trash, I mean, everybody's got an opinion on this. What we need to realize is that although it's categorized as the Patient Protection and Affordability Care Act, that's not what it actually is designed to do. It's designed to improve access for 32 million people who otherwise wouldn't have access via an insurer. And this would mean some form of government insurance, which pays about 65% of the actual cost of delivering that care. So what Russ was referring to, I think, in this group, particularly in the greater Charlotte market, is you have two health systems that have made a commitment to provide charity care programs for those individuals in our community that may be less fortunate than many of us in this room. So what we have to take a look at is our cost structure going forward. The denominator is going to remain the same. In other words, we're still going to have the same amount of dollars in many cases, and we're going to have more people showing up seeking this care. And the social compact of individuals like Don and his fine company taking that ownership and taking care of those individuals is going to be much more of a challenge. So the health systems are going to have to take a look at how we look at our cost structure and how we can break even on government rates, which are lower than commercial rates, to provide this care. And the way we're going to have to do that as we go forward, we're going to have to strategically grow and meet the needs of our community, but we're going to need to be more precise in our operations and manage our controllable costs and be more accountable for that going forward to the communities we serve.
Well, Russ mentioned individual employers and lifestyle. I guess from a research perspective, you know, what else should we be doing to support what you're doing?
The region is very young in terms of biotechnology and life sciences. I mean, when you think of North Carolina and you think life sciences, you think the Triangle region, and we're not there yet. However, we are on our way. If you look at the research campus, the types of research that's going on there falls at the intersection of agriculture, nutrition, and human health research. So understanding that biotech does not necessarily mean just human health. It can also be ag, it can be food, and starting to draw attention to the different types of organizations that are in, not only at the campus, but also in the area, would be a start in terms of growing this field here. You know, we talk about the North Carolina Research Campus because I'm from there, but there are several groups across the region that are making strides in biotech and life sciences. The first one being UNC Charlotte, with all the basic research that goes on there, as well as the small spin-off companies that come out of some of those research labs. Kennan Research Center, various clinical research that goes on at Presbyterian, various private companies in the region. As an economic community, supporting these groups, identifying, bringing capital to the region to grow this field would be a very big step in pushing this along as an economic driver for Charlotte.
Thank you. John, over the last couple of years, I can speak for our little organization. We've seen some substantial annual increases in our premium, insurance premiums. Is that trend going to continue, and if so, what can we do to reverse it or slow it down?
I think there are several places, and I want to make a point of agreeing with my colleagues on the end in a couple of areas, and then also talk a little bit about what I think is some of the realities. I will admit to being a recovering academician, so to the extent that I wander off on a policy wonk kind of thing, forgive me and draw me back in. But I do agree that access for the indigent in Charlotte is better than many communities. Blue Cross actually just recently sponsored a free clinic. We sponsor free clinics all over the state. But we still have numbers of folks who don't even access the good facilities we have available, and there's no doubt that we have significant socioeconomic and racial disparities in health outcomes, and we cannot look the other way on that. I would also agree that lifestyles, healthy lifestyles, it's really my main project with Blue Cross Blue Shield, is a significant piece of the answer. Unless we change our own behaviors and those that are out there at the McDonald's 3 times a day or whatever, we will never make progress. And the obesity epidemic has not abated yet. That said, the pig is already in the python. Baby boomers are an overweight, inactive group. I am one. I'm trying to be a little more active than some of my colleagues, but we already have significant health care costs that are going to play themselves out. So when you ask about what health care increases look like over time, health insurance premiums will be driven by health care costs. To the extent we can be more efficient in how we deliver that, that's fine. But we have got a population that is getting older, has an increasing number of chronic conditions, and will need treatment. So I think, again, we can look forward to, just from healthcare costs, exclusive of healthcare reform requirements, that will continue to increase at least 6%. Again, doubles or triples what we anticipate in terms of gross national product and disposable income.
Several of you mentioned, improving our nutrition and lifestyle, and then you specifically mentioned McDonald's, kind of synonymous, I guess, with unhealthy eating. But several communities around the country, in particular New York and several parts of California, have gotten involved in attempting to legislate ingredients that are considered to be unhealthy and limiting individual access to unhealthy drinks as well as food. What's your perspective from the medical professional perspective? How involved should government be in trying to head off this epidemic that you guys seem to be alluding to?
So, let me... Sheila, what did you say? So, let me go back. I wanted prohibition work. This is about individuals taking accountability and changing their behaviors. And there's got to be a reason to do that. People are not stupid. The economics of this are that fatty foods are cheap. And for folks who are in economic pinch, many can't even get access or good access to the healthier foods they need. Now, some of that's just learning and behavioral that we can do something about. And I do think that's ultimately where the answer is, that we as providers, nutritionists in particular, need to help people understand what works, what doesn't work, what's healthy, what's not healthy, portion control, eating healthy but tasteful. I think there are a lot of things, and I do see it as an individual accountability and personal behavior change as much as it is a governmental piece. The government can certainly help in terms of food labeling to the extent it doesn't get so complicated people can't understand it. And providing an environment, healthy places to walk, safe playgrounds on which to play. I think it's a pretty big social issue, as much or more than it is a medical issue.
Before I go to other panelists, anyone in the audience have any questions or comments on this topic? Because this particular subject touches all of you and all of us directly. Yes, sir. John?
Sheetal ought to speak about what's going on at the research campus a little bit more, because they're really analyzing how foods affect the body, and that knowledge, that education will help a lot of people eat more healthy foods than they are now.
Absolutely. So our founder, and to give you the 30-second rundown of what's going on in Kannapolis, we have a research campus that is the vision of David H. Murdoch, who is a self-proclaimed advocate of nutrition. Here's a gentleman who is almost 88 years old and in probably better health than I am. He has assembled a collection of universities who have various programs that are going on how food and nutrition play a role in human health. We have groups that study the impact of exercise, the impact of various plant components in health, and then also going over to the disease state, look at how various foods, natural products can influence disease, whether it aggravates it or alleviates it. So just a big hodgepodge of research that is going on there. But the ultimate goal of the campus really is to improve the human condition through food, through healthy eating and healthy lifestyle. To go back to some of the comments you made about walking and taking care of yourself, the campus is designed inherently to put the employee in an environment that is healthy. So we have a restaurant near our campus called Restaurant 46, and the human chromosome has human has 46 chromosomes. Everything in that restaurant is healthy. It tastes very good, but it's very healthy. And we have walking trails that are planned. We have bicycles that Mr. Murdoch has purchased. So if you're here and you want to go over there, you instead of driving, you walk or take a bicycle. So it's pretty much this community that is founded on the same principles that a lot of you up here are talking about, and so it fits very well into some of the other activities in the region.
There's a step a little bit further. They're actually analyzing switches that affect DNA. Can you speak about that at all?
It's not my research, so I'm not going to try to butcher it. So.
They're learning.
But it's really a looking at something from a crop to the actual food. Once a crop is harvested, how to keep those nutrients in those fruits and vegetables intact, to what happens when we eat the food and we digest it and the nutrients are released into our body, and how they affect DNA, how they affect changes, how they affect disease states, and then all the way to exercise. And then I believe in the future there will be definitely a more educational component on the campus as well.
Great. Anyone else? Yes, sir. Carl?
I have a question for you, Don.
Speak up a little bit.
Okay, sorry about that. Are there any incentives that you all give to firms that, let's say, they were able to lower their healthcare costs, or folks are healthier, maybe from years past, you all have incentives, that sort of thing, that kind of assist instead of it just being increased, that sort of thing?
In fact, we do. We have a number of incentives around healthier lifestyles. For larger companies, we have a program where a company will have an employee earn a portion of the company's contribution to the premiums based on taking healthy activities. We have our Blue Points program. We have a number of healthy education programs, online programs to help folks do that. We had a pilot actually for our individual business where folks who had actually changed their lifestyle over a period of time could be asked to be re-underwritten to a healthier class from where they started. This all, though, will be impacted. I don't know whether you're looking to transfer into healthcare reform, but many of these incentives will go away with healthcare reform. It's a good thing at one level, in terms of not differentiating people based on their health, but it also impacts folks who are making healthy decisions, and that they will not get some of those benefits. But yes, we did program.
Yes, Fred.
I'm sure you're aware of the statistic or the projection of the statistic that by the year 2020, 50% of the U.S. population will either be diabetic or pre-diabetic. That in conjunction with all the other illnesses and disease that are taking place now and will continue forward, that would mean that more than half the country is in a state of disease. What are your thoughts on that?
So, a couple of things. One, for someone who can find a non-needle-based insulin, they're going to be in great shape. I'm not really being facetious on that. I think there are technological advances to be made in the treatment of disease. But in terms of its impact on healthcare costs, and again, if you look at the obesity epidemic, there is a parallel line with diabetes. So they are directly related. It also goes along with osteoarthritis, and thus the biggest cost increases we see, for instance, are in orthopedic procedures, hip replacements, knee replacements. Great technology, extremely expensive. So again, this is what I was saying about the pig and the python. We've already swallowed that population, and they're going to have to play through. There will be some impact by improving lifestyles on those who have a chronic condition. But what my hope is with the children and our younger generations.
Russ, I saw you cringe there.
You did? Occasionally my color are better than that. I was just thinking earlier, in the question, what should we do about obesity? And I would compare it more to what would we have done if we knew how dangerous tobacco was when it first became an issue. And I think, we obviously did very, very little for a long, long time. And I don't know what the role of the government should be. That certainly is beyond my purview. But I do think this issue of obesity and the populations that it's specifically damaging makes it something that we cannot ignore, and we cannot just hope it'll go away, because I think it is very much something that it's not. Yes, there are the baby boomers, but this is children that are being affected at an earlier and earlier age all the time, and the schools need to play a part in this. The government needs to play a part in this. We need to play a part in this. I think it's something that it's very, very important. What I do cringe is when I see the U.S. compared to other countries as a percent of what we spend on health care. We are not like those other countries. We are not like Japan. We are not like Sweden. We are not like Finland. We are not like France. You have to look at this country and the diversity of this country and the things that this country stands for. A lot of those things create a lot of cost. Our trauma network is busy. It's booming. We have a lot of trauma in this city that, you wouldn't have in a lot of countries. We have a lot of diversity, so it's very, very different. But if you are looking at just the healthcare component in terms of, yes, we treat a very sick population, and that results in a lot of costs. If the population was a healthier population, you would have a lot less cost.
Yes, John, go ahead.
Let me just kind of lay out how I think about healthcare costs. The first is, and we've already really referenced it pretty much, is that we have an increased prevalence of disease that we want to treat. The second piece is we have redefined what constitutes disease. When I started in practice, if your blood sugar was below 250, everybody was happy and you go home. Now, if your blood sugar is not within 100 to 110 and your hemoglobin A1C is less than 6, you're sick. And that's a good thing, by the way, because it leads to healthier outcomes. We also have things that we call disease now that didn't used to be diseases. And I would reference virtually half of the direct-to-consumer advertising you see on TV. If you can't sniff out of both sides of your nose equally, by God, you've got a disease that you need to take care of. So redefinition. The third is it costs more to treat the same disease. An appendectomy now costs 2.5 times what it did 10 years ago. And there are a lot of different reasons for that, but it's more expensive. The fourth is technology. Again, we said that's great. It is also expensive. And the last is redundancy, waste, and inefficiency. Upwards of 30% of our healthcare dollar goes to redundancy, ineffectiveness, or inefficiency. And as we look forward to trying to cut the healthcare cost trend, I think that's the first place we would go. This is where what the Institute of Medicine calls dark green savings. They are real dollars, and by and large, they won't hurt anybody except those that are providing redundant.
Can you give us some examples of redundancy?
So, if someone, I'm going to pick a different locale.
We're about to talk about rebates.
So, if someone goes to UNC and has a procedure, goes to the emergency room, and they end up with a CT or an MRI, but because they happen to be there, and then they wander across town to have their follow-up care, what's going to happen? First thing Duke's going to do is repeat the MRI or CT. You know, this is the hope of health information exchange and electronic medical records, is that we'll be able to cross-pollinate here. I will tell you that when you look at the healthcare systems, we're not there. You know, this isn't health information. Free health information exchange is not here. So that's at least one example of redundancy, and there are lots of others.
Well, excuse me, Mark, the National Health Information Network system there, is that a step in the right direction?
Obviously, whenever you're having conversation around advancement of information, particularly around patient safety, it's a step in the right direction. I would like to say a couple things based on the comments that were made before. Number one, I think we're probably closer to that number than you might think around the percent of folks that have a certain disease, whether it's diabetes or what have you. Upwards to 50% of cardiovascular disease goes undiagnosed until there's an episode. Chest pain, heart attack, something along those lines. Many of us have some type of cardiovascular disease, we just don't know it. So I think it's probably a little higher than we think. I'm also encouraged by what's going on in the research part. I will tell you, I read an interesting story yesterday, and I won't get the newspaper right, so I won't quote one, but there's a new use for tobacco. There's actually a strain of tobacco that's being used for H1N1 vaccine. And creative minds like Dr. Gilani's and others that are looking at what was once not determined to be such that bad for us, then was realized. We had so many people addicted to it, they went ahead and used it. Now it's being used for alternate sources. So I want you to imagine a world 25 years from now where we think of tobacco in a much different way. No one would think of using it for smoking or anything like that, but it is a source for vaccination. As far as information exchange, I think it's, number one, the key needs to be that it's patient safety driven. Okay, it's got to be access to information. But I also will tell you that there are other factors. And I won't sit here as the leader of one of our organizations and tell you that we all have to maintain what we're fearful of. Number one, most physicians, I think they still are trained in a rule-out method. Meaning, rule out this disease, rule out that disease, rule out the other disease in a protective mindset. And that means that in order to rule out this disease, you got to do this study. And so I think there are lots of studies that are ordered because the individual, if you've ever had to talk to a physician who has to defend the position they took on the care for one of their patients, it's a very scary time for them. So until we overcome that obstacle, it doesn't matter if they had a CT scan yesterday at Duke and one of our physicians here sees that person and they're not sure and they don't have, they're going to order that test. That's a perverse business model, okay? It truly is. It may be what's in the best interest of an individual. It's not what's in the best interest of the patient. Number one, to expose them to unnecessary radiation or pain and suffering if it's any type of intervention in any way. And also, if we have the information, it's available through an electronic medium. I think we have brilliant doctors in a lot of hospitals in this country. We ought to be able to share information immediately.
Yeah, so a hand over here, I'm sorry. Yes, sir.
I was wondering if we could switch back to healthcare reform for a little bit.
Go ahead.
Congress seems to be determined to kind of rehash the argument all over again. And I'm just wondering from your various perspectives, if members of our panel would be willing to share maybe one thing you think we should keep from what was passed, and one thing you would change if you had the opportunity.
Well, I'll go first. We can go down the road. I guess certainly one thing I would keep in the healthcare reform is no pre-existing conditions, especially the one that went in this year, which is no exclusions for children. So, go right now.
Yeah.
I really have, this is kind of beyond what we do.
Sure.
So.
Okay. Appreciate your honesty. All right? You can't get away with that.
I would say our Blue Cross Blue Shield's position on healthcare reform from very early on has been it is the law of the land. And if there's anyone in the room that doubts that we need to vastly improve our healthcare system, I don't know where you can live it. I think there's no question that we need healthcare reform. The question is what does it look like? In terms of what would I keep, we need access. Massachusetts has access, 93% are covered. Gets to the second piece of it. What do they have? An economic disaster. The cost was not really addressed in the legislation. This was health insurance reform, not health system reform. There are a lot of pieces that kind of hint towards it, comparative effectiveness, HIE, a lot of different pieces, but the cost has not been addressed. And access without really making sure we get value for the care that's delivered will be a continuing issue.
I agree with Dr. Bradley in that we need to, number one, define value. What's the key performance indicator as a healthcare system, and make sure we're delivering that to the community. The thing I like is the fact that we have access to health care for everyone who's in America. I like that. I think we ought to have access to health care. We need to figure that out. What I don't like is that how can you continue to provide quality health care when you're going to see cuts in reimbursement? So you're going to see more people and you're going to get paid fewer dollars. That's a model that's unsustainable. Fortunately, we live in Charlotte. And we have communities like Raleigh and Winston and Asheville where they can thrive. If you imagine a place where you're a standalone community hospital, they can't stay open under that model. They will not be able to stay open under that model. We'll have large pockets of our country that won't have access to quality health care because they can't pool and share resources across their community. They just don't have it.
Well, continuing in that vein, and this week is very timely because of what's happening in the House of Representatives relative to healthcare legislation. And I don't intend, no desire for this to be a political discussion, but there's a significant divide on several areas depending on which side of the aisle you sit on. And then I guess from your perspective, number one, there are those who say the existing legislation will drive up the cost of health care as we know it, as well as will drive up the cost of insurance in its current existence. Now, from your perspective, is it true? Is that true or not?
Well, part of this legislation was to provide insurance coverage to more than 40 million uninsured Americans. Part of this did not cover all the illegal immigrants. We still treat all of those people. Make that very clear. If they come to our emergency room, they're admitted, we treat those individuals like we treat everybody else. So, first of all, there's still a lot of people this did not even attempt to address. But those that it did attempt to address, the 40+ million uninsured, about half of those would come in through an expansion of the Medicaid program. The other half would come in through an expansion of private insurance that would be heavily subsidized by the federal government. Those two buckets of money are supposed to come from cuts to providers and increased taxes, and some other areas as well, but and cuts to insurance companies as well through the Medicare Advantage programs. But it's supposed to be sort of a wash. What I've never seen quite before in any legislation is the disagreement over that. It's not in the tens of millions, it's in the hundreds in billions of dollars of disagreement about how much this is really going to cost. I think the expansion of this program, you know, it's a fabulous idea. The way it was sort of like laid out, you know, in terms of Medicaid today, a lot of people think Medicaid is for the poor. It is not for the poor. Medicaid is for those who are pregnant, have children, and are indigent. But if you're a male, in general, you're not eligible for the Medicaid program. Okay? This expands Medicaid to people who are poor for the first time ever. And that's a great idea. It also encourages people who can't afford insurance today through Blue Cross. The government will pay up to 80% of that premium. I'm not sure how you do all that and it doesn't cost more money. I mean, I know that we're supposed to, the hospitals are going to be cut $150 billion. There's about $500 billion out of the provider side that will be cut. But even that, you know, again, if you're looking at 45 million new people, you can see why there's a lot of discrepancy and a lot of doubt. And in most of these kind of programs, the government does tend to miss the target by a big number.
Mark?
I would agree. The Congressional Budget Office has projected it would cost $940 billion over 10 years, or $94 billion a year. About half is going to come from decreases in spending and half the new revenue from taxes, as Russ stated. What I would tell you is that it's going to be interesting. And when you have more people to care for and fewer dollars coming in, you have to look at what services you can actually provide and what communities you can provide them to. And what I'll tell you is that I do think that this is a transformational healthcare. And we're here today to talk about Charlotte, the greater Charlotte area. I think we need to transform our way of viewing our community as it pertains to healthcare. Number one, all of us in this community need to accept that there are those in this community that we need to help improve their access to health, whether it's through the free clinics we talked about, whether it's finding a primary care provider that will take a government payer. In many cases, they're closed out, and that's in both systems, okay? They just can't take on that one. They can't sustain their practice and take on any more government payers. So we need to look at how we own it in our community and realize that there are things beyond our control. And how we react to those things, I think, is truly the thing I'm most optimistic about. We've had 100+ years in this community with healthcare presence, now with two systems, close to probably 70, 75 years. And we have just begun, I think, over the last few years to be more collaborative in how we manage the care in this community. I think there's things that we need to collectively give back to the community, particularly around those that are in that bucket of the 32 million that are going to need improved access to health care. So I think from our standpoint, we're going to do more good for the community when we, as business leaders, healthcare leaders, and elected officials collaborate for what's in the best interest of our community as a whole. And not try to solve it in a silo. This is complex. We're all fairly smart people, and the way we come together and have collective ideas, I think when we get through this, it will look differently today or in 5 years than it does today. You know, we look at the Medicare and Medicaid Acts. I think they've been around for 45 years or so. We're still trying to understand those. They change every year. So I think our children will still be working through this in some version. But I think as a community, now's the time to come together and figure out how we're going to solve it for our community and understand that hopefully there are smart people trying to solve it for a nation.
I would agree. I think our success will be based not on how hard we negotiate, but how well we collaborate. Keeping the patient in the center of the discussion. So I think, you know, we will have to remind ourselves that we're all running businesses, but we're all about the patient, and that will be us as well. So I think that will be the key. That will not be easy. Conceptually, we've had numbers of discussions with a number of providers. Conceptually, we're all there. It's when you get down to how does that actually work that matters. And I do have to make one comment on government subsidies. Healthcare is not cheaper when you have government subsidies. It's just what pocket are you taking the money? Most all of us pay taxes, and those government subsidies are not coming out of the air. They're coming from our taxes. So as we look particularly, and it's important to listen to what gets stated. The budget will go up or the budget will go down, okay? Tell me about the total healthcare cost, because when we look at it as business people, that's what impacts how much money we have left to do the other things that we're supposed to be about. So I do think we've got, you know, there's some very good things in this bill, particularly as a physician. I support, you know, preventive care at 100%. We absolutely need that, but it will add cost. We will have no lifetime limits. Good thing. It'll help a number of people, but it will add cost. So just understand that it isn't free and it isn't coming out of the air. We're going to have to make a collective decision on what we want to do. And again, we've got to do it with the right spirit.
Yes,
Thanks, Ronnie. Morning, Ronnie. You know, we read so many articles about actually how much medical cost is incurred at the end of life. Do you see any changes there in terms, you know, I've seen, you know, quotes of 80%, 70%. Do you see anything changing the way we approach that reduces that cost?
I'll share an opinion on that one. I think that one is always easier said than done. We talk about, you know, we need to change our behaviors around our eating habits, smoking, more diet, exercise. About 14 months ago, my 93-year-old grandmother fell and hit her head. She was at a small rural community hospital in Wilkes County, and they said they're going to let her peacefully die. My uncle said, no, you're not. They put her in a car and got her to another facility in a larger city in Winston-Salem, and she's alive today. Okay, when you're dealing with your own 93-year-old parent or grandparent, it's a much different story. So I think it's easier said than done, but I think all of us, when we have our loved ones, whether it's a child in a nursery, a NICU, intensive care unit, or a great-grandparent that's in their 90s, you cling to those memories to the point you want to try everything if they can stay with us. That's a hard thing to overcome because I think we're a benevolent society and we want to give back to those individuals for what they've given us over the years. So my opinion is I think that one is a very tough cultural shift that I don't think aligns with most of our value proposition as Americans.
Don, do you have a perspective to that question?
Well, it's hard for an insurance company to have too big a perspective on it. Let me do this as a physician. I think the two hallmarks of the American healthcare system, for which I make no apologies, are choice and control. And this is another one where I think people, particularly towards the end of the life, need to be able to express their own choices about what they like. And what we have not done as a provider community, to me, is to really encourage folks to take control and have their own choices about what they want out of it. So many times, what happens is you're trying to make ethical decisions at the bedside. That is not where you make ethical decisions. This needs to be done by individuals. And I'm going to give you my personal example that my father, both my parents are 80 years old. They both work full time, which tells you one thing about it. My father has given me a 32-page algorithm for what he wants done should he get into an acute session. I can't get my mother to do anything. Living will, power of attorney, anything. So, and they are different people. And I will keep pushing on it to the point that I'm disowned by my mother. But again, we are not helping people understand that this is about their own autonomy, choice, and control. And those discussions need to be done at the provider level. An insurance company can't go out and, what was the term, death panel? Anything I say about that as an insurance company becomes a death panel. But again, it is really about, again, patient focus, patient autonomy, patient control, patient choice, and that's where we can, and we should be able to make progress. But I agree, it will not be easy. Again, just look at my parents. One, he's there, he's got it. The other, I'll keep trying.
Ross?
I do think it is one of those, third rails that, the government's not going to touch. On the other hand, from a provider point of view, we spend a tremendous amount of time on palliative care, on talking to patients and their families about palliative care. We do so much more with home care today than just a year or 2 years ago in this regard. And then, of course, we have some of the best hospice care in this community you could ever hope for. There are other places than the intensive care unit, without a doubt. And we have to make sure, from a provider perspective, that those options are provided to our patients and their families. But the number is, extremely high. What percentage of the healthcare dollar we spend in the last year of our lives. And that can come down, but it takes a lot of education. And a lot of the physicians, though, are